Very good.
Okay, so let's get started. Welcome, everyone. My name is Emilia Andersson, and I am medical. Oh, maybe we can ask participants to mute. And I'll unmute myself. Okay, my name is Emilia Andersson. I am a medical lead for oncology diagnostics in Roche, but I'm only here to welcome you all to this interpretation workshop by CADQAS, who we are very, very proud to sponsor. And we're happy that we are able to sponsor it yet another year. And we are looking forward to many more sessions and proficiency tests this year. So today, the topic is HER2 immunohistochemistry, and it will be presented by Corrado and Simona Costache. And you have also opened the module so that everyone can go in and score cases. And after that, we will reconvene and discuss the challenges and discordances. I also wondered, Corrado, maybe we've had some questions on the web page. If you would like to update people on that a little bit. So
Yeah.
I give the word back to you. Thank you.
Thank you very much. Fantastic. Thank you, Emilia. Thank you all for joining us. We had some changes in CADQAS. Sarah Whedon has retired, who's been the program director for 10 years plus. Now we are in the process of regrouping and reorganizing. You would have seen some changes. So, for instance, at the beginning of the circulation, we produce a very short interpretation guide video, a minute or two or something like this, just to refresh memory and to remind how these biomarkers should be interpreted. Of course, HER2, it's kind of something that everybody knows about, but this will be more important when we do circulation on clothing, for instance, or things like that. The workshop that we do at the beginning is kind of a little bit of a repetition, so we don't expect everybody to stay with us for the workshop, but obviously we understand that there are new participants that haven't heard this, so we produce it at the beginning of the circulation. In any case, all these workshops and also the proficiency testing feedbacks are recorded, so you can go on the website and listen to this. And Hannah is breaking all the cases, so you will have little video of one case at a time to see how we interpret it and so on. So there's little changes that we introduced, and also you probably noticed that there is an expanded program for this year of proficiency testing, because there are a lot of other biomarkers that have been introduced. Some of them are sponsored, for instance this one by Roche, and some others we just bring them to you without sponsors. But we continue to try and keep these programs to be free for the pathologists, because we think this is very important. Okay, so
some complaints about the sound, louder a little bit. Maybe closer.
Louder.
Maybe you can closer.
Okay.
Let's try.
Okay. Is this a bit better? Hopefully it's better. I don't know. We will see. So fantastic. So to go to our workshop, we need to say presentation.
Yep.
I guess we do that, and we don't like that. Now what?
More to the right?
This one. Okay, we're getting
Yes.
there. And then we want, I really like my laser point. Fantastic. Okay. So thank you very much for Emilia to continue to convince Roche to sponsor these programs. So that's the agenda. We are going to talk about the context, the therapeutic context of these tests in breast cancer, and then a little bit of background on how did we get here historically, because actually it helps us become a better pathologist, become better interpreter of these tests. And then I would like to we'll go through the interpretation algorithm, but I'd like to...
Corrado?
Yes?
Yes, we're getting several comments here that the sound isn't too good. So could you move your mic? closer.
That's a very good question, but I don't know. Let's stop share
You're
and see whether
already
I can.
better when you talking closer.
So is it just a matter of being more forceful?
Maybe.
I think so. Yes.
And speak louder. Okay, we can do that. Sorry, thank you. Okay, let's go back to share and find the PowerPoint. God knows where it is. Here it is.
Lovely.
Fantastic. Okay, so if we go back, how do we get rid of this thing?
You just put it low.
So the staining patterns, I think this is an important part of this little workshop, because we need to recognize patterns. We are pathologists. Pathologists recognize pattern. It's not just a matter of positive or negative. We need to understand that staining patterns are important. This is not part of this. And hopefully there will be some questions and answers time at the end and case studies. Okay, next. Okay, these are disclosures, not important. Okay, so the context. The context is that until recently, few years back, and therefore before the Destiny Breast 04 reported, the HER2 immunohistochemistry was really a simple affair. It was either positive or negative, and it was based on the fact that we had to treat these HER2 amplified cases. HER2 overexpressors, but behind overexpressor there is almost always amplification. And so the scheme was 0 and 1+ were negative. In fact, none of us bothered, and we couldn't really care.
Somewhere with a dash, 0-1.
It doesn't matter. Indeterminate was 2+, not so sure that it's positive or negative. We had ish, and then the 3+ had positivity. Fantastic. But DB04 told us we need to identify this category here, IHC1+, because these patients respond to the antibody drug conjugate that was the topic of this trial, which is an antibody that uses HER2 as a target to home a antibody loaded by chemotherapy agents that are then internalized, released, and then interfering with the cell metabolism. And so HER2 negative was still negative, the 0+ was negative, but now the 1+ was called HER2 low. So we had to introduce this new diagnostic category. HER2 2+ still needed ISH to be resolved, and then if ISH was positive, amplified, we would call HER2 positive. If ISH was not amplified, we would call it HER2 low. Cool. And then to increase complication, DB06 reported, that's probably about a year and a half ago or so, and that is identifying a further diagnostic category, which is this ultra-low, this IHC0 with some membrane staining, as different from IHC0 and not a sausage, nothing to see.
Yeah.
And then, of course, lots of pathologists started to say, oh, come on, you will always find one cell. Everything will be ultra-low. And actually, that's not quite true. You know?
There are some.
But
very few cases,
some cases
indeed,
that are
completely
null.
negative.
Okay. So now, for diagnostic categories, the traditional HER2 positive, the HER2 low that we knew from before, from DB06 or 4, and now the ultra-low. And now the 0 is we kind of adopted this word null, meaning there is no staining. Okay, so that's the landscape. And how do we select these patients? We use immunohistochemistry. Why do we want to use immunohistochemistry? Originally, because nobody could do in situ hybridization to the scale of breast cancer patients. There are tens of thousands per year. So immunohistochemistry was a good surrogate, and of course ISH was the reflex test just in case when you weren't sure. But now that we are chasing the protein, this low and ultra low, ISH doesn't help.
Nope.
It doesn't matter there is amplification. Well, of course, if it's amplified, then you have a different treatment, but it cannot tell you. Maybe we should have a messenger RNA in situ hybridization to measure the amount of message that there is, but we are not there. So we use immunohistochemistry. We'll follow. Who knows? Okay, and this is a little kind of diagram to talk about sensitivity in immunohistochemistry because the test of HER2 that we use is not the real immunohistochemistry test. It's something that has been watered down, diluted, dampened down, but we kind of forgotten that, so I think it's better to remember. So, in general, people say that the limit of detection, LOD, of immunohistochemistry, when you talk about membrane staining, so these are molecules you see along the line of the membrane, is around 3,000 copies per cell.
Yep.
It's a number, don't be too hung up to it, it's a kind of general number to give an understanding. And just to give you an understanding, this limit of detection in immunohistochemistry, 3,000, was here, but we were looking for cells that have millions of copies of HER2. This was the thing.
In order to be positive.
This was the HER2 positive, And HER2 positive, and then around 1,500,000 is, I don't know, uncertain. Is it amplified or not? But below 500,000, it was clearly not staining very much. It was a 1+. So, the problem with the HER2 test is that originally, if you stain the breast using this limit of detection, you stain the breast epithelium.
Yeah.
Yeah? And that created confusion and started to say you need to subtract the amount of staining in the breast epithelium to the amount of staining in the carcinoma, all kind of things. To cut a long story short, the test was then set up so that it wouldn't show breast epithelium. So the normal breast epithelium kind of has around, let's say, 20,000 copies of HER2 per cell. Because normal breast epithelium needs HER2.
Yep.
Yeah? Okay. But the test was designed not to show it, or even sometimes show it, but really, really very faintly. So this is a shift here. This was an artificial shift. Okay, so, and the convention was that, you see, if you stain the breast with a test, kind of almost don't stain the normal, but obviously stain the tumor. Okay, cool. And so what you couldn't stain was called IHC 0, and what you could stain strongly is 3+, and then we said that kind of strongish, but not as strong as 3+, was this 2+, we need ish. And then anything below that, you could comfortably call it negative. It's 1+, is negative, don't worry about it, etc. Cool. Now, let's say this is the typical IHC curve, is asymptotic. This is the amount of antigen on the tissue section, so cells have more and more of this antigen, and this is the immunoreaction, the antigen-antibody complex with the DAB that precipitates, and these are our eyes. These are our limit of detection. At very low level, we don't really see any staining. It's our problem. Yep. So there is a limit of detection. Then we see weak staining. Then we see moderate staining. There is strong staining. And then eventually the system saturates. Even if there are more antibody conjugates there, you don't perceive anymore. So these are the limit of detection. And pathology is what the pathology traditionally did with immunohistochemistry: 0, 1+, 2+, 3+. Yeah, that's how it worked, And the breast HER2 hijacked this 1+, 2+, 0, etc., etc. And for a period of time, these were the same, Only afterwards, we started to make rules. 2+ is circumferential or call like this. So there were other parameters, So it was not just staining intensity.
But it's still, even nowadays, it's still when you're calling it 1+ equal negative or 2+ equal, it's not a clear understanding, not even today, that one is the IHC score and it translates to a result.
Yeah. So that's what we need to understand. What Simona says is that I know we use pluses, but it's not the same plus as when you're scoring a CD20 or a CK5, Okay. All right. So this is the typical IHC test. We said, next slide, that
Yep.
if you actually use it, you will stain breast epithelium. I did that, I took the mask off the test, and you can stain breast epithelium. It's nice, yeah? Cool. But the clinical IHC test, the HER2 test we use really, has decreased sensitivity. So it doesn't stain, this it has a weak staining in the carcinoma, but this one is negative, this normal breast lobule. Okay, but the warning is this, that there isn't one clinical IHC test, let's say for the 5. There are many. There is the 001 DACO monoclonal, there is the Leica 3B11, there is also the polyclonal, rabbit polyclonal. So all these tests, they are not as sensitive as the typical IHC because they've been dampened down, but they are not all equivalent. So they are engineered to distinguish well the strong from the not strong, but the low level in staining intensity, which is now very, very important because of the HER2 low, HER2 ultra low, etc., they will not perform the same. And, there are lots of publications that show that they do not perform the same. So understand that. Now, the next question is this clinical IHC test reliable? And despite all the rumors you have heard, the clinical IHC test that was originally designed, that is positive negative, for HER2 amplify, is really very good. There are very, very few discordant cases, 96% concordance. That's blooming heck. This is really good. Pathologist 96% concordance is really good. So it's a very robust test, and the robustness of the test is because we understood how to interpret these 2-tier, positive, negative. Now we have 4 tiers, and we need to understand this interpretation of 4 tiers. So this is an attempt, it's an interpretive algorithm. There are many in existence. They all work the same. So we need to determine staining intensity. To determine staining intensity, we use magnification rule. And then the next bit we need to understand is whether the staining in the cell is circumferential or partial, because that dictates an action. And the third element is to understand how many of these cells have these changes. And then all of these together, and we'll look at it more in details, will create an IHC score. Now remember, this IHC score, as Simona was saying, at the beginning were the same, 1+, 2+, 3+, the same as we would score any other immunohistochemistry. But then, now they have different meaning. Is it complete? Is it incomplete? Is it 10%? Exactly. Is it more than 10%?
But I do think this algorithm, and also, like you said in the short video, which I do recommend to everyone to see it and to share it along your colleagues, it's if you can make it your own and understand it per se, it's so easy after that to score each case. And what some colleagues are saying, but it takes a long time, especially the HER2, I think it's one of the most easiest case.
No.
Quick.
Really?
Yes.
We say that HER2 takes milliseconds.
Yeah.
Let's call it seconds. Let's say 5 seconds. You can do it in very.
No, this was the only computer. I asked Anne, and she said no.
But we have an extraneous voice, yeah. But of course, you will see that there are 1 or 2 cases that are more. You need to spend more time with it. Okay. So remember IHC scores.
Yep.
Then you need to couple this with whatever the regulatory approval is that say ultra low you can give for ER positive, whatever it is, and then eventually you have these categories. These are the diagnostic categories that will give you some actions. Can use the drug, don't use the drug, etc., etc. Okay. Now, we saw 96% concordance. I don't think that was a funny paper. I think we are robust in HER2, positive, negative. But how do we now perform when we have all these other diagnostic categories? That's the trick. Yeah. And the reality is that there are lots of publications, but you see as you now want to have concordance in low, ultra low, we break down. There is no concordance. I mean, when things go to 40% concordance, you think, come on, that's not. But why? Why is because I don't think everybody understands the algorithm. So the first thing to achieve concordance is set up rules.
Exactly.
Then obviously,
and then follow them.
Yeah. So do a little bit of training, but also, and we will see also later, also because all these interpretive algorithms, including the guidelines that ASCO-CAP, RCPAT, etc., give us, they don't tell us what is actually real staining and what is not real staining. Exactly. So the staining patterns, Okay, so we will do that. So these are more examples. You see, the figures are rubbish. 99% two-tier classification, positive, negative,
and then
goes down to 3 tiers, and now we have 4 tiers.
Dropping.
And you see, 40% of core biopsy reported 0 are reclassified as low. That's worrying,
Yes.
Okay.
But also we do need to take into consideration here that even if we are very robust in this classifying, you are adding a new meter that you need to take into consideration, which is the percentage.
Yes.
And then on a core biopsy, you do have less tumor. And then on excision, you do have more tumor.
Okay, so
then you could understand, though, this shift of percentages, that it's
sampling,
less concordance
sampling is
of
a
sampling.
problem.
Yes, because in the moment that you're adding a meter of percentage here, you are in the hand of the surgeon how he is putting the needle
through the biopsy.
Yes, and how much tumor you have.
If there is heterogeneity in the tumor.
And also, yes.
But also, we also need to be adult about it. Somebody said that there is a threshold of 10%. I don't know why. I don't know what biological purpose 10% has. It's just a number, man-made number. However, it is there, But you need to understand that when you're looking at 300,000 cells, to know that there is 9.9% or 10.1%, it's impossible.
It is a little bit of eyeballing at some point, but...
So we need to accept that there will be cases that sit across the threshold that will generate some confusion.
Yes.
Fine, but this should not be very many. Cool, okay. So interpretation algorithm is based on 3 elements. Staining intensity, we'll use the magnification rules. Distribution of staining, we'll have a look at it. And then number of cell staining.
And I will make a comment here, exactly in this order.
Exactly in this order. Okay, so if you go to American websites, like people like me that have lots of time on their hands and surf the web, you'll realize the Americans do exactly the same, but they do it the other way around.
Yes.
But we think this is better.
But never mind. It
doesn't
At least
matter.
for us, it works very well.
But it's the same concept.
Yes.
The same concept
Yes.
is like this. Okay. So that's the scheme of things, and again stressing the fact that at the end you will get an IHC score that will then translate in something down here. These are your diagnoses. Okay. So staining intensity. This is Joseph Rushoff, who has normalized the field of staining intensity, because before he forcefully imposed it on all his colleagues, we were having discussions on the microscope. No, I think this is weak. No, I think this is moderate. No, I would call this strong. Or no, I think this is strong. There was no uniformity in these things. So then he said, no, let's use the microscope. If you can see it at low power, that's strong.
Yes.
If you can only see it when you put times 10, that's moderate. And if you really need to put high power, that's weak. Okay?
Yes.
There has been an evolution during the years, but nevertheless, this is kind of the soup of it. And this is a practical approach, but actually has a physical reason, which we will not go into it. It's about the laws of optical devices, and there's been a lot of science associated with it. But believe me, the reality is that the highest the numerical aperture of your lens, the more details you see. So I know it's called magnification rule, but it's nothing to do with magnification. It's nothing to do with magnification. Look at this. This is times 60 and times 40, okay? Look at this. The numerical aperture
It's the
of this
same.
is the same. The resolution is the same. This is half as bigger,
Yep,
you know,
yep.
but it's not as if you see more. It's the detail is the same. Okay, call it magnification rule. That's what we call it. But again, your microscope has a graded series of lenses that actually they do change magnification. But what more importantly, they change the numerical aperture, which makes you see more details. So you can only see a very coarse line at low power, but you can see a much finer line at high power.
Yep.
And therefore, the line thickness, so Joseph has understood that you need to associate line thickness with the 3 plus, 2 plus, the staining
Exactly.
intensity. That's the revolutionary concept. Okay, so that's what we are. And in this context, after the normalization of the HER2 field, in came PD-L1, which blew the minds of many good pathologists, me included. We couldn't understand the thing about this blooming PD-L1, especially because unrealistically, any faintest stain, almost imperceptible, was positive. And so we fluctuated between calling everything negative and then going to feedback meeting to say, no, you're all wrong, these are all positive. Then the next time we call everything positive, and then a feedback meeting is, no, these are all negative. You know, and we could not get our head around it. But pertinent to this, we learned that lines that you see only at very high power, they may not be real. And this is the famous checkerboard illusion.
At high
Tell
power.
me.
At
A
high
very
power.
microscope,
So that means very faint lines.
very faint line.
Yes,
May
sorry.
not be lines.
Yes.
Because your brain may say, there is a
there
line
is a
there,
line, yeah.
but there isn't a line there. And in fact, this is maybe the reason why there is discrepancy between image analysis and pathologists, because image analysis measures whether there is chromogen or not. Pathologists say, well, I think that's I follow my brain, I'll say positive. Okay, so this is the famous checkerboard illusion. It's an illusion, it's not a trick. So it's based on the fact that we are going to compare the staining intensity, think about cells, of square A and square B, clearly different. This is a white and this is a dark, yeah? And the problem is that obviously the brain is going to interpret this because there is a context, there is an object casting a shadow.
Yep.
And that's the problem. And in your slide, there is always a blooming context. So be careful, okay? Right, so I made 2 circles and I copied the staining intensity here with the eye drop, whatever it's called. These are the same, yeah? So if I take this and put it on A, it will be exactly the same. You'll notice exactly the same. If I take this one and put it on B, clearly it will be darker than B.
Yep.
Do we even need to discuss this? No, it will be darker than B.
I must confess, I did not believe him first time. I was like, nah, now you changed the colors of the circles. But he didn't. Live, he push it on top of the other one.
Yeah. This is the way it is. And what is this? This is my brain saying this cannot be a dark thing. I'm telling Corrado this is white, so it doesn't worry. Life goes on, okay? So be careful because your brain may tell you that there are things that are not real. So we have learned with PD-L1, if you can only see something at very high power, think very carefully. It may be real, but you need to exercise more of your pathologist skills. Okay, so the distributional staining is very simple. Is it complete, circumferential, or discontinuous, incomplete? Okay, and I will tell you there is another element, and that's why we need to recognize patterns. So this should be quite easy. That's circumferential, it's one line, and this is got gaps. Okay, so keyword is mind the gap, and there is a warning side here. Why? Because sometimes morphologically there are type of breast cancer they do not manage to do circumferential. They have all the intentions to be circumferential. But they can't because these are secretory surfaces and the HER2 receptor doesn't get there. So we now recognize that the U shape is also continuous circumferential. Okay, and this needs to be read in the context of the right morphology. These are micropapillary carcinoma tumors. And incidentally, this is a relatively new-ish observation, which we learned by studying gastric cancer, because then gastric cancer HER2 went to gastric cancer, and then a lot of gastric cancer were U-shaped. And we said, well, how does this work? And then,
But that's still a gray area with the gastric
cancer is a great pain in the neck.
Okay,
so there's something new. It's not that new, but anyway, something new. So you need to concentrate on the gap. Mind the gap. But why the gap is important? So this is a particular technique that allows you to visualize a single molecule spatially with a very, very high spatial resolution. It's called something like quantitative single molecule localization microscopy. Is an interpolation. It's based on fluorophores that are caged and activated and unactivated. Okay, and it's a computational thing. It's not like you look down the microscope, you see that. But however, using this technology, I understood a lot more about this issue than before, because we were always told a receptor goes into the membrane and is equally distributed along the membrane. The same spatially, if there are more, they're closer together. If there are less, they're closer. There are more space spatially. It's kind of like a molecule of gas in another gas. It occupies. Yeah, not true. Not true. Actually, a lot of these receptors are in clusters. So this is the visualization. Each dot is a single molecule, but you can see there are clusters and there are spaces. And these are cells with different numbers of HER2. That says here, so many molecules per micrometer square, less and less. But even when there are fewer molecules, they are still clustering. Clustering is a fact. Okay, so that's my question. Why, when this is a kind of density that we say 3+, why with this density we see continuous lines? And why with this density we see discontinuous lines? Okay, and that's because here you see a single molecule. In immunohistochemistry, DAB, chromogenic, you don't see a single molecule. You don't see 10 molecules. You see a lot more molecules, and these rely on the fact that the antigen-antibody complex, then it has derivatives, polymers, etc., a lot of enzymes, and there is the chromogen that goes in, precipitates. And this precipitation accumulates, and these are single molecule of chromogen falling on top of each other and becoming bigger and bigger, eventually becoming visible, because a single molecule of chromogen, nobody will see it. So you start to see that staining the moment you have a splodge of a certain amount. But if you think of splodges that are very separate from each other, that's where you have this continuous line. And when you have splodges that are closer together, you start to see continuous lines, okay? So this may be an explanation. So what I wanted to tell you is that although we say complete versus incomplete, the variable thickness is also important. Is it uniform? Because if you achieve uniformity, you have a lot of molecules there. When you don't have a lot of molecules, you may have an area of strong staining, but the other areas of weak staining, and then smaller, thinner line. Okay, so some patterns. We need patterns. How are we doing for time? Good. So we see pattern. You see, it looks as if some of you may even say strong staining, but look, there are beads and gaps, small gaps, but variable intensity. So to me, just a look of it is this is a classical pattern of 1+. That's what it is, Same here, gaps, 1+.
I would say that some of our colleagues would call this a 2+.
And you
we
can
have
do
many reflex cases like this of a 2+.
Of course.
And they are the majority.
And you need to, you need to achieve some comfort and confidence. Do the dishes on this, and then you realize, you can correlate these things. Gaps. You see how this one seems to be an emphasis on the crossroad of 3 or 4 cells. These almost like birds' feet. Now, of course, we have guidelines by professional bodies. But none of the guidelines tell us about patterns. They say 1+, 2+, blah, 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 10%, etc. But nobody tells you learn patterns. Actually, that's not true. ASCO-CAP continues to be ASCO-CAP, whatever. But RCPath says the detailed description of the various expression patterns may improve concordance. They understood that you need to start to be a pathologist. Stop being a counter. Be a pathologist, recognize. Okay.
But they're not giving us the patterns.
But they're not giving it. But we'll have a look at the pattern. Okay. So let's see some patterns that are actually not membrane staining. I'm not sure that they are not membrane staining, but what I can tell you is these are not things that are scored as membrane staining. Okay. So this is this luminal, extracellular type, almost extracellular, maybe glycocalyx staining. Yeah. There it is here. It's fuzzy, it's always in the center. The
like
cells
like
side by side.
Scaffolding
Like
of the
side by side, no membrane staining. You know? Okay, so that's not membrane staining. Another one that has transpired when we started to pursue this 1+ HER2 low and HER2 ultra low, basal membrane-like staining, there are these lines that are always between the cell and the extracellular environment, never between the cells. Okay, so be careful about this, you know. I must say, like many others, I used to report this as 1+, but then I learned this is not 1+, this is an artificial and non-recognized membrane staining. Here is another example at high power. Every now and again you can see membrane staining.
Yes.
That's actually different. The pattern is different here, you see? Okay. Cytoplasmic staining. And now, remember those checkerboard illusion. Maybe you can tell me, Corrado, there is also membrane staining here.
Exactly.
Okay, there may be membrane staining, but be careful that this is not a trick of your brain. So,
it's quite difficult to
think
interpret
carefully.
like this.
Think carefully, yeah. Again, the cytoplasmic staining may be very weak. And again, you could kind of trying to convince yourself that you can also see lines. And yes, there may be lines, but how do you know these are not gray lines? And your brain is saying, I think I should put some brown here. So that Simona is up here with me.
But I think in this kind of cases, it's worth mentioning in the report as a separate comment to say, I note mild and focal cytoplasmic staining, or especially on the previous one with basement membrane-like staining.
Yes.
Because like you said, the case can be reviewed, or a colleague can look upon it and will be, oh, did you not notice membrane staining?
There's membrane staining. So
and maybe he's not picking it up, that is just, because, time is limited.
So it's worth it.
It's worth to make a point and to
here,
write it down.
You know, this is another pattern I would have happily called 1+. But actually, do you notice it's fuzzy? It's not a line. It's just, this is cytoplasmic staining. Well, you can argue there may be a little bit of membrane staining, but predominantly, most of the brown we see, I think, is cytoplasmic. So there are staining patterns, such as this one here, where clearly there is granular cytoplasmic staining. But I think maybe many of us will say, well, I think I accept that this is also membrane staining. Possibly, you know?
Yes.
And you know, we say here, interpret. You know, it's probably membrane staining, but you can say that, but with caution. You know, think about it before you just jump.
In this case, it's not just our mind telling us that we see membrane staining.
Probably not, and because also, you know, the slide. I mean, obviously, this is a high-power photograph of a few cells, but the slide will contain many examples of different things. So you can reassure yourself that actually probably there is membrane staining in there. I agree. This is another example of granulocytoplasmic staining. You know, don't mistake this as a positive membrane staining. And again, here there is an extreme case. You have nuclear and cytoplasmic staining. We call this non-specific. We have no reason to say it's not specific. Who knows? It could be very specific. We don't know. But it's certainly not. Does not identify the cases we need to select for therapy. That's what I wanted to say.
But is there a specific reason why is it happening like this?
Well, we don't know. These are tumor cells. How do you know that they do not produce a shortened version of HER2 that is immunoreactive with your antibody, but that is localized to the nucleus because it's fused with another product? How do we know these things? You know, nobody has the time to study in detail Why do we
So
have
when we
this
are
kind
calling
of
it
thing?
non-specific, it's not quite a non-specific, because it's not like an artifact, just an
No,
artifact.
I don't know if you remember. I don't know if you remember in PDL1 they said, oh, if you have nuclear staining, it's non-specific.
Yes.
Until somebody produced a paper and say, look, this is a cell cultures. I can this particular cell line, I can demonstrate that there is PDL1 in the nucleus. What is it doing? I don't know, but it's there. I can extract. I can run gels. It's there. So non-specific. It is not a pattern we say we accept. Okay, staining pattern, specific staining pattern. This is the strong chicken wire, if you want, pattern of 3+. This obviously is DCS, but here you see these few little cells of invasive carcinoma. This is a very early stage of invasive carcinoma. We saw this before. These are U-shaped, but probably the staining intensity is not as strong. If you compare the staining intensity of the previous one, so probably you could probably call this 2+. 2+ in recognition that it is a continuous membrane staining because it's U-shaped, but in micropapillary, but it's not strong enough, and maybe there are also some gaps. Then again, this is a staining pattern, sometimes U-shaped and complicated by cytoplasmic staining, but I think many of us would be happy to call it 3+.
Though.
Yeah.
And I think this is more a good example, but whenever you have that very strong intensity of a 3+, you will always have a little bit of rim of cytoplasmic staining around it.
And it's logical, these are molecules producing the cytoplasm and then transported, so it could be, this is another example of continuous membrane staining. Okay, so now the staining intensity is less. And also there are gaps. And also, more important, there are thin and thick. This is not uniform. So these are 1+ staining patterns, beads on string, 1+ staining patterns. You see these beads, these blobs. Why are they blobs? Because there are not enough molecules to make uniform distribution of this staining. Again, beads, and little accentuation at the confluence of the membranes. More of these things, Again, this is an example of U-shape, weak, but also discontinuous. Okay, this may be a U-shape, but actually it doesn't have a nucleus, so I'm not sure even it counts, because you need to have a cell with nucleus. But here there is this cell, there are gaps here. I can't call this continuous by any shape of imagination. So sometimes the staining is very weak, and you may want to put high power to confirm to your eyes that this is indeed membrane staining. But often, if you don't have a perception that at times 20 there is staining, and you can only see at times 40, you need to think carefully about this. Okay, and again, weak and also blobs. There are blobs here and there and gaps. So these are all discontinuous 1+ staining pattern. Now, it becomes very important because we need to classify 1+ low and 0 with membrane staining ultra low. That we recognize very weak staining. So this is an example of possibly I perceive that there are little lines, little dots and lines, but I need a high power to make myself reassured that this is the case. And again, so we need to...
Corrado?
Yep.
We have a comment. If you could please just suggest the scores for each of the images.
Okay, I will do. So these are all examples of 1+ score staining patterns.
We will have more in a second.
Hopefully we'll have some case studies if we go faster. Okay, so again, these are all examples, even sometime a dot. You see this dot here, but it's a dot in the right place because it's between cells in where I would place a membrane. So even one dot could be acceptable for, so here there is discontinuous membrane staining is weak. It doesn't matter, the staining intensity is not strong. So, but it's in more than 10% of the cells. So to me,
in this field, we're going to talk about the picture per se.
So this would be an HER2 low. Again, all of the cells, or most of the cells, are staining with this crow feet arrangement. 1+ staining pattern. again, more example of this 1+ staining pattern. Sometimes the staining is continuous, but you see there is something odd about this picture. I don't know whether the nuclei are not very nice and there is a bit of smearing and smudging. So be careful about tissue preservation when you assess. Yeah.
Yes, and especially when you have like this with tissue preservation, you need to be very careful. And for a case like that, it might be even high nuclear grade, especially if you have ER negative, PR negative, put it in the context, choose an indeterminate category and reflex it.
Yeah.
You need to,
exactly. So when you suspect that something has gone wrong with the tissue, then you say, okay, let's do another test, just to make sure I'm not missing the amplification cases. Okay, so more and more cases. So here you see you have cytoplasmic staining. And it would be tempted for somebody to say, oh, look, there is strong staining, let's call it 2+ on the basis of strong staining and reflex to IHC. But actually, this is cytoplasmic staining. It's not scoreable. What is scoreable is the thin lines, the membrane. You need to put it in the morphological context, what you see. Okay, so more and more of these examples of this discontinuous staining. Hopefully, we made the point. Okay, so what is the algorithm? So, first of all, you determine the staining intensity. How do? You put ×4 or ×5, whatever your microscope has, and you screen the slide. If you see membrane staining, it means it is a strong staining intensity. At which point you need to answer the question, do you see complete membrane staining or is it incomplete? Let me tell you something. ASCO-CAP say this doesn't exist. Most of us that do this game tells you we see them. They are not very common, but we see them. So if you find incomplete membrane staining, strong with this tau power, that's the course of action is do an ISH. Because it could be that you see incomplete because you have a failure of fixation, and you are going to throw in the bin something that could be amplified. So do an ISH. If it's not amplified, don't worry, call it whatever you want to call it, 1+ and move on. But if it's complete, for some reason, you apply the 10% rule. Now, I'm not entirely sure how many of us will apply the 10% rule. We can discuss that. But the 10% rule is, if more than 10% of the tumor cells show complete, circumferential, strong staining, we call it 3+.
Yep.
In reality, most tumors either have wall-to-wall or no wall-to-wall.
Yes.
And whenever we find a tumor that has an area, we always ask the question, why don't we do a DDISH, just to make sure that we are studying these things properly, because they are rarer cases. So although there is this 10% rule, I think most of us will reflex if it's just that kind of thing. To ISH.
But wouldn't
Sorry?
you also say that this is a case of heterogeneity where you can have a clonal?
Exactly. It could be. It could be. Yeah. It
but
could be.
What are you doing if it's not a clear demarcation, if all the tumor, now and then, it has that strong intensity, but now and then you can see it is not quite complete membrane staining.
Yeah. So these are two case scenarios.
And it's more than 10%.
So these are two case scenarios. There are tumors that genuinely are heterogeneous. They have cells that do and cells that don't.
Yeah.
Or areas of the tumor that does and areas of the tumor that don't. But there are some tumors where there seems to be a mixture.
Exactly.
And then when there is a mixture, the first question you have to ask yourself is, am I being fooled by some biochemical phenomenon? Somebody didn't fix it properly, somebody didn't process properly, the antibody wasn't delivered well, whatever it is, And because we have a reflex test, and because at that point we are looking for the amplification, well, find out if there is amplification. Usually, if you find a heterogeneous 3+ on core biopsy, you report it as focally 3+, but you will repeat on excision.
Yeah.
How much of this tumor is affected, And if you have metastases, are the metastases 3+ or not 3+? Where do they come from? So these are rarer cases, Emilia. They are cases that will deserve different handling. We are talking about the generality. That's what we probably do. So we spoke about it. But if on scanning at low power. You don't see lines. Now, with Simona, we play this game a lot. But when I mean you don't see line, I don't mean you're going to strain your eyes until you get a line.
Exactly.
No. Can you see it comfortably? No. Okay, that's not strong staining. That's it. So then you say, I really need, your brain says, please, can you put times 10? I want to see more clearly. Yeah?
Yes.
At that point, you are falling into the moderate staining intensity. If you see lines, these are moderate staining intensity. So remember, once you fall down here, you cannot call something 3+ anymore.
Yeah.
The only way you can call tumor positive is to go through ISH. That's the
Always.
only resolution here. So let's say we say, yes, I can see lines. Again, I ask myself complete or incomplete, to remember the U shape, all these type of things. And I ask myself the 10% rule, because if I can see in less than 10% of the cells, I call this case 1+. I don't even reflex to ISH. Again, a lot of pathologists will say, I don't really care about this 10% rule. Let's do ISH, just in case.
These are the majority of reflex.
But in general, this would be the rule. Okay, if instead is incomplete, if you find moderate staining incomplete, there is not even an arrow that go to ISH. Forget about it. This diagnosis is no longer tenable.
Yeah.
You lost it. We are now going to decide whether there is more than 10% HER2 low or less than 10% HER2 ultra low. That's the only option. You can put higher power.
Just to convince yourself.
And you need to put higher power, especially when you say, I don't know, there may be less than 10% incomplete, I don't know, something like this. Because as you put higher power, you see more cells with more lines, so the 10% is easier to reach. So you need to do that. And it could be, although these are much, much rarer cases, where you didn't see circumferential lines at times 10, but you start to see at times 20. So again, the action, it doesn't matter anymore if it's weak or moderate, the action will be the same. If you do see circumferential line, I think you need to reflex to ISH. Circumferential tells you something is happening, something strange is there. Go and have a look. And then, of course, if you don't see anything, you have a 0, and then you need to decide, is there 0 but 1 or 2 cells, 5 cells, 10% of the cells, 6% of the cells have a little bit of membrane staining, we call it ultra low, or nothing, not a sausage, null. Okay, that's the algorithm.
I think it looks a little bit
confusing.
You might say that, but it's, again, I think rule of thumb, you put low magnification, times 4, in the moment that you swap, there is no longer a 3+. That's not a case that I can, it's a less probability that I'm signing out the case today, let's call it like this, and I'm seeing staining over there, I'm seeing color. Then it will be a matter of, is it 2+ and I'm reflexing it, or am I putting even higher power and it's 1+ or 0? So
fantastic. But the algorithm looks complicated, but actually when you do it, it's very quick and very easy. Okay, so just a few
we did
notes.
say about the suboptimal analytics.
Okay, so
just don't call it 2+, because it's not a 2+ staining. Call it indeterminate.
Call it indeterminate, because 2+ is a staining category, and then somebody will pick on you and say, how did you call this 2+? No, I called it indeterminate because I'm not happy with preservation, or happy with staining, the thing is lifted, whatever it is, for other reasons. But so people don't pick on you. Okay, and then just remember now your report needs to contain these details. 3+, 2+, 1+, 0 with membrane or 0 with no membrane staining, and these are kind of things. Okay, I'm sorry because
2 or
we are
3.
kind of
but like these people can join us for the feedback session where we are going to have also a club,
a slide club,
and we are going to show you even more very interesting cases. Yeah.
Okay, so these are photographs. Will be all the same. Sorry.
Before you show more cases, there is a comment here. If you could comment on the amount of tumor that you consider enough for reliable HER2 scoring.
I think you need to use your judgment. There are no rules. You know, when somebody says 50 cells or 100 cells, these are numbers picked up from the air. You need to, sometimes the core biopsy contains very little tumor. Yeah. You do report what you see. If you report, if it's 3+, you say 3+. If it's whatever it is, you do your work, but you make a note and say, there is very, very few tumor.
And recommend don't repeat on
excision. You need to repeat the excision. So if you then go to your tumor board, to your multidisciplinary meeting, and the oncologist says, oh, because of this HER2 status, I'm going to do this, you say, hey, wait a moment. Yeah. If you really want to act on it now, take more tumor. Don't rely on such a small amount of tumor for this critical decision. Okay, so these case studies, they have 4 microphotographs times 4, 5 times 10 times 20 times 40. And so you can play the magnification rule. So for instance, time 4,
yeah, you
I don't
see it takes only 10 seconds to report the HER2.
Nothing here, yeah?
Nothing there.
Time 10, I can see lines.
Are they complete?
No.
Okay.
So these are moderate staining intensity. Yeah. This continues. This is 1+ staining pattern. I'll check on times 20. Still not complete.
You still see lines and more lines now.
You see more lines.
And even more lines.
Cells. But are they circumferential, complete, uniform?
Very rare, if any.
Okay, so this is 1+. This is a much, much higher power, and where you can see this continuous staining intensity and so on. Okay, and if you want it, you can do DDish. This is not amplified. Okay, so this would be the final diagnosis for us. This is another case study. Again, the same crib. Something, but I don't see lines.
Might even be in situ there.
Maybe in situ, you're right. Can't see very much here.
So you're already at times 10. So 3+ went, you're at 2+ now. Can you see lines? Not even. No. So you already went with the 2+.
Now this is moderate staining. This is moderate. This is low.
So you have at weak.
Weak staining there. I can see lines.
You are seeing lines. A few. Is it more than 10%?
That's debatable. Maybe not.
Debatable because it's just a tiny photograph. If it's more than 10, then it's 1+. Yeah. If it's not more than 10, then it will be 0 with membrane staining because we have membrane staining.
Okay, so somehow we decided this was more
probably
than 10%.
We had, yeah. Okay, we had more.
So that's another case. Nothing. Maybe. Yeah. But actually, I can see something here as well. So it's not, this doesn't appear out of the blue. Oh, at times 40 now we can see a new world. No, there is something here that I'm not so sure. And now, okay, maybe I believe. You can consider, maybe believe. So there it is a much higher power. Probably yes. So would this be a case of ultra low? Because it's in a very, very few cells, less than 10%. Not because it's very weak.
Yes.
But because of the number of cells
exactly.
involved. Okay.
Once you're already at weak staining intensity, it's about percentage.
One more case, and then we are up the hour. So I see brown, but no membrane.
So no more 3+.
Maybe there is some membrane staining here, very discontinuous. I'm not 100% sure.
So no moderate.
This one?
I can see some dots.
Maybe some dots, some discontinuous. There they are.
There
At time 40, you can now see.
There are
little dots, little
so you
dashes.
Have weak staining.
Weak, but in more than 10% of the cells.
But in more than 10, so it's a 1+.
Let's see what we decided. I don't remember these cases. 1+, yeah?
But we don't need to remember the cases. Okay. That's if you apply the algorithm, and it's quite easy. That's why if you use the magnification rule, if you use your objectives, that it's quite...
Very good. Okay, so we stop here because it's the top of the hour.